In the dialysis round today, we will see one common problem as a medicine resident or someone who was working in the casualty who encounter. The call or the reference comes like this. So a patient from the periphery center. The dialysis happened today only, but potassium is high. Potassium is 8. Or, so despite dialysis, potassium is 8. What is my diagnosis? What is the other differential? See, before going into the other differential, you should know something. Why not the dialysis is inadequate? There are centers where there are no proper nephrologist or under proper guidance. If it is not done, the clearance might not be achieved. The dialysis might not be adequate. That is why the patient presents with hyperkalemia. Even though dialysis got complete at 11 o'clock, 2 o'clock potassium might be high because dialysis itself didn't happen properly. So whenever you are getting hyperkalemia or low clearance in a patient, always check where the dialysis occurred, whether the proper measures are taken or not. So what are those things which can affect the clearance? Let me give some short or important ones here. For example, the dialysis is occurring, you can see blood pump is rotating. The problem can occur at the machine level or at the patient level. First at the machine level, what are the things can happen? See, here it is the dialyzer, blood is coming, dialysate is coming. Suppose if this dialysate composition, part A, part B, water, if there is any issue, the alarm will glow and ring, but this dialysate will cut off. There won't be any dialysate supply this side. Only blood will be rotating. That means dialysis is not at all occurring. Sometimes this bypass alarm, this here you can focus that bypass alarm is there, bypass release, that will be glowing. Even if you leave out this screen, any dialysis machine, dialysis might be cut off, blood will be rotating, dialysis might not have occurred. The technician might not have noticed this dialysis alarm is ringing. There are centers where 10 machines might be there, but only 2 technicians might be there, technologists. They won't have enough time to focus on this and adjust this. Sometimes they might miss, sometimes they might not be aware in some peripheral centers. Only the machine, this is rotating for the patient and the attenders, yes, dialysis has been done, but inside no clearance have occurred. First one. Second, the dialyzer inside that microcapillaries are there. Multiple times they might reuse it. 5 times, 6 times, 7 times without any quality check. The dialyzer might not be effective. Whatever the amount of blood goes, nothing is going to happen if the dialysis membrane is already damaged. Second one. Even in the freshly used dialyzer, there will be clot inside. Suppose if heparin is not given or for any circumstances, the clot is formed. Blood won't go. Yes, the alarm might come if the pressure is high. But at the ground level, there are microclots where pressure is not affected but capillaries are blocked. Again, dialysis won't occur, clearance won't occur. The clot will be there. That is why it have to be checked every time. Whenever dialysis occur, our technologists always come and look for the clot. Clot have to be looked. If the dialysis blood is not flowing, clearance won't occur. And the fourth one. Blood is coming in this direction, dialysate is coming in the opposite direction. That is called counter current flow. Counter current flow increase the clearance. Suppose if patient is getting co-current flow because of some either patient condition and the dialysis prescription is not matched, or if the technologist is not aware, this co-current dialysis might be given. The blood is flowing in the same direction, dialysate is flowing in the same direction. If both goes in the same direction, clearance won't be that effective. That co-current is for some other situation. So it is a patient specific decision. Agar hyperkalemia, if it is there, the decision have to be focused on clearance. That might not be there, that might be missed. And a very common one, blood flow. See, 300 ml per minute for 4 hours. That will be different kind of blood flow. The amount of blood going inside the dialyzer is different compared to 180 ml, 220 ml per minute. That will be patient-centric decision. Suppose if clearance is warranted, higher blood flow might be required. And in absolute one sentence answer, it is very difficult to tell. It depends on patient risk of other complication like CNS related complication. Blood flow will be adjusted. Hemoglobin is there. So multiple parameters have to be taken into consideration, because sometimes the student used to ask, even a dialysis technologist used to ask, sir, what is the blood flow I have to keep? There is no one word answer. It is a multiple other parameters have to be taken. This video pertaining to clearance, I am telling. Blood flow, if it is low, clearance won't be there. So these are mission related things that I spontaneously told regarding these 4 parameters. Clearance might not be there. Suppose if everything is there, what is the patient related problem? Vascular access. Fistula might not be functioning well. The cannulation might be very, very nearby. The machine is cleaning the blood and giving to the patient, and the same blood will again enter the machine. It is called a recirculation. It is just rotating. 200 ml or 300 ml of blood is just rotating between patient's upper limb and the dialyzer. It is not at all entering the circulation if the access is not cannulated properly. And at the ground level, many a times fistula needle instead of artery and vein, the connection might be ulta. They might connect the venous side to artery, artery side to venous. Very, very common. These technical terms probably a technologist or medicine resident who completed your dialysis posting will understand. For others, it will be a bit difficult to understand connecting this line in a different direction. With related to fistula, I told. Even with related to femoral line. See, femoral line, it will be around 11 centimeter or 12 centimeter. 2 holes, holes are very nearby. If there is a mild resistance above, the blood will start rotating inside only. It might not reach the circulation. The best example is DVT, deep venous thrombosis, partial DVT. The blood will be rotating there only. Then also clearance won't be there. Any vascular access problem, these 5 parameters I told, will lead to poor clearance, will lead to high urea creat, high potassium LVO despite after dialysis. So that is why those who are in casualty, even if you get the history dialysis occurred today, make sure you are getting the KFT done and you are keeping this DD. Ask this at least basic detail and you might have to give the dialysis again. At least in summary, I hope these many parameters is affecting the clearance, including the patient vascular access. So this idea you should know to handle the CKD, especially dialysis cases. And for nephrology resident, it is a must know knowledge. Okay, bye bye. We'll see you in next video.